right, everybody, can you please take your seats so we could get started with our final panel today, which is on the current state of play, a conversation with experts in policy and economics. So thank you very much. So I am excited to introduce Lauren Aronson, who will be moderating this final panel. She's the Executive Director of the Campaign for Sustainable Drug Pricing, or CSRXP, and a partner at Melman Consulting. Lauren's a health policy expert with an insider's understanding of how to get things done in Washington. She leads a CSRXP, which is a coalition promoting bipartisan, market-based solutions to lower drug prices in America. The coalition consists of physicians, nurses, hospitals, consumers, health plans, pharmacy benefit managers, pharmacists, and business. Lauren joined Melman Consulting in 2015 after time at the Centers for Medicare and Medicaid Services, or CMS, where she directed the Office of Legislation and led the agency's interactions with Capitol Hill. She served as a professional staff member for the House Ways and Means Committee, working on Medicare Advantage and Medicare Part D payment policies. She's also served in the White House under President Obama as the policy director in the Office of Health Reform, and was a key member of the administration's team working to enact the Affordable Care Act. Lauren, thank you for joining us. I'll pass it to you.
Great, thank you. Well, thank you to Kaiser Permanente and the Institute for Health Policy for always hosting such a fantastic event. Looking forward to our discussion today. I'll start by introducing our panelists, and then we'll get into lots of different topics of conversation that are at the forefront of drug pricing today. First, we have Polly Webster. Polly is a senior health counsel for the U.S. Senate Finance Committee Democrats. Her portfolio includes prescription drug issues across the Finance Committee jurisdiction healthcare programs, including the committee's recent work on pharmacy benefit managers and drug shortages. Polly was previously Vice President of Federal Affairs at the Association for Accessible Medicines, which advocates on behalf of generic and biosimilar medicines. She also served as a Principal Policy Advisor handling pharmacy and prescription drug policies at Kaiser Permanente, so I know this feels like coming home. It does. And on Capitol Hill, Polly served as Congresswoman Diana DeGette's Health Policy Director for a number of years, spearheading the Congresswoman's work on the 21st Century Cures Act. She also previously held roles on the Senate Finance Committee in Senator Jay Rockefeller's office. Polly received her bachelor's from Denison and her master's degree in public health from George Washington University and her law degree from Georgetown University. On my far left, not to be mistaken as our Republican on the panel, that was not by design, but I'll take it, is Connor Sheehy. Connor is a director at Levitt Partners, a bipartisan multi-client firm where he assists stakeholders across the healthcare sector with navigating federal healthcare policy landscape. Prior to entering the private sector, Connor spent 8 years on Capitol Hill, most recently serving for 4 years as senior staff on the Republican staff on the Senate Finance Committee. While there, Connor led the Senate GOP on prescription drug policy, including the Chamber's consideration of the Inflation Reduction Act. Connor later co-authored the committee's bipartisan pharmacy benefit manager reform legislation with Polly, as well as proposals related to medication shortage mitigation, clinical payment improvements under Medicare. Before that, Connor spent 4 years in the office of Senator Tim Scott, ultimately serving as Deputy Legislative Director. Connor taught for 3 years in the Bronx as Teach for America Corps member while earning his master's degree, and he received his BA from the University of Virginia, which he attended as a Jefferson Scholar. And then to my left, we have Marta Wyszynski, who is a senior fellow at the Center for Health Policy at the Brookings Institution. She's a healthcare economist with a particular expertise in prescription drugs and experience spanning academia and federal governments. Dr. Wyszynska served as a director of the Bureau of Economics at the Federal Trade Commission, chief healthcare economist at the Office of Inspector General at the U.S. Department of Health and Human Services, and director of economics staff at the U.S. Food and Drug Administration's Center for Drug Evaluation and Research. She also served as an economic advisor to the U.S. Senate Finance Committee, providing drug market analysis and expert guidance for the committee's bipartisan investigation and legislative work on drug pricing. Dr. Wyszynska was a consulting professor and deputy director for policy at the Duke Margolis Center for Health Policy at Duke University and an assistant professor of marketing at Harvard Business School. Dr. Wyszynska serves as an expert witness in pharmaceutical antitrust cases. And finally, but not least, we have Anna Keltenbach, who is the president of Verdant Research. Prior to this role, she was principal and head of prescription drug reimbursement practice at ATI Advisory. A health economist, her work focuses on how federal and commercial reimbursement policies shape the market for prescription drugs and new health technologies. Anna also served as a senior health advisor to the Senate Finance Committee, where she led on drug pricing issues, including Medicare direct negotiation and prescription drug reimbursement provisions. Previously, she was a program director at the Center for Health and Policy Outcomes and the Drug Pricing Lab at Memorial Sloan Kettering Cancer Center. Anna earned a BA and MA in economics from Tufts University and an MBA from Yale University. So with that, I'm very excited to dig into this discussion. There is so much that's happening on the issue of drug pricing, both in Congress and in the Trump administration. So we're going to dig right in. And Polly, I'm going to start with you. I think the Senate Finance Committee has been doing a ton of work over the course of the years and looking at Connor and Polly and Anna for quite some time, and Martha as well. You all had your time with the Finance Committee. I feel a little bit left out since I was on.
This is a good day for Senate Finance.
Yeah, I will hold the table for the House Ways and Means Committee and the administration, I guess. But in all seriousness, there's just been so much happening in the administration, in Congress. So given your current work with the Finance Committee and Ranking Member Wyden, can you talk a little bit about what Senate Finance Committee Democrats are focusing on, notwithstanding, obviously, OBBB, everything else that's been happening, but drug pricing played a little bit of a role finally, but can you talk a little bit about what the committee's priorities are?
Yeah, no, sure, I'm happy to. And first of all, thank you, everyone, for having me. It's great to be back at Kaiser and see so many familiar faces and former colleagues' faces. So great to be here. Yeah, there is a lot on the agenda. I think I would be remiss to say, Lauren, to your point, OBA, or reconciliation accountability, is first and foremost. I think, Democrats are viewing this as a devastating blow to the healthcare system. And even though there wasn't that much drug policy in the bill, I think that OBA accountability and sort of where do we go from here is going to be kind of overshadowing everything in terms of how Democrats are thinking about how to move forward, across all of health policy in general. And that will certainly bleed into, any work that we're doing in the prescription drug space as well. I think on drugs specifically, it's, once again, as it always feels like it is, a very, very interesting time in Washington. Obviously, like Anna and Connor did so much work on the Inflation Reduction Act, and now Medicare drug price negotiation is law, and certainly it will be a huge priority for Democrats to defend against any potential further attacks on negotiation, and hopefully on a go-forward basis think about how to build on that success and strengthen it. But at the same time, we also have a president who has, talked a lot of big talk about taking on the pharmaceutical industry, has thrown ideas out there about international reference pricing and most favored nation. And I think from where we sit, having lived through a lot of the same rhetoric during the first Trump administration that, wasn't able to fully get off the ground, Democrats have questions about the seriousness of that effort. But regardless of what and how this manifests, I think that it has moved the Overton window once again on Capitol Hill about what is doable in the drug pricing space. And certainly that is top of mind for Democrats, as well as we're thinking about how to build on things like what we did in the Inflation Reduction Act and Medicare drug price negotiation. How do we take things to the next level and take advantage of a situation where, even some Republicans seem to want to be getting more aggressive in the drug pricing space. So those conversations, I think, are pretty nascent. And then I think the other big priority in drug pricing is that a lot of members on our side of the aisle, certainly recognize abusive pricing practices on the part of manufacturers, and that's going to continue to be a focus. But I also think there's a growing awareness of the role of other stakeholders in the supply chain, like what, we tried to go after some of that in our work on PBM reform. And I think that there's a growing appreciation that too many stakeholders are making money off of drug margin or forms of compensation that are linked to drug prices, such that those entities get higher payments when prices are high. And so I do think that there is interest on the Democratic side and continued bipartisan interest in trying to do what we can to sort of clean up those supply chain dynamics that don't serve patients.
Great. Well, thank you for that. And I kind of want to pick up and kind of looking at you where Polly sort of left off. I mean, in the Trump administration first go around, there was a lot of talk about drug pricing. There was an executive order. There was numerous regulations. Some, were not followed. Some did not, fully go over the finish line. Some were held up in litigation. So, thinking a little bit about where the first administration is and then now Trump 2.0, can you talk a little bit about, to the extent you're comfortable, kind of the Trump administration perspective, and then also how are congressional Republicans sort of responding to it?
Yeah, it's a great question, Lauren. I should start off also by saying thank you so much to KP for having me. This is a great opportunity and a terrific panel of people and friends and colleagues. So really grateful for the opportunity. I should also say, especially given the sensitivity anytime the president's name is invoked, that I'm speaking only on my own behalf, not on behalf of Levitt Partners. If there's any retribution or punitive consequences, it should fall squarely on my shoulders. And I think with that in mind, there's the Forrest Gump line about life's like a box of chocolates. You never know which one you're going to get. I feel that way with press releases from the various federal agencies in the White House. I think some of them taste better than others. I wouldn't say it's been a perfect track record to date. I think as we try to think about coming up with sort of a unifying framework or principle or lens through which to understand the administration's approach, I think it's impossible because there's an awareness that the president won re-election this time around on the back of a relatively politically diverse coalition. And it's folks with a lot of competing interests, and I think in some cases conflicting interests. And I think if you look at it through that approach and don't expect cohesion or consistency so much as a lot of the greatest hits from the campaign sort of playing out in diverse policy buckets, that's been the way that I've most been able to wrap my head around it. I would be lying if I said I could completely wrap my head around it. There could be a new CMMI model dropped over the next 10 minutes that says we're going to deport every pharmaceutical manufacturer CEO in the country, and I wouldn't be totally shocked. So I think with that in mind, in the unpredictability, I think there are a few different buckets that are similar to what we saw, at least rhetorically, the first time around. I think the policies coming out of them, in some cases, this is like the sequel, right? It's bigger, it's bolder. I think sometimes the sequel's not as good as the original, but again, mileage may vary. And so the first one I'd point to is America First rhetoric was a defining component of both the first and the second Trump election campaigns. And I think we saw that play out a lot rhetorically in the first Trump administration through talk about tariffs and in some cases imposition of tariffs, through talk about the desire to ramp up domestic manufacturing. And I think in the course of the Tax Cuts and Jobs Act, at least some effort to flesh that out with some policy meat. And I think most notably for what we're seeing right now in terms of headlines, there was, as Polly alluded to, there were a number of different proposals that would have been pretty disruptive changes to the prescription drug landscape. I'm thinking about the International Pricing Index, later finalized as most favored nation. I guess we have to call it 1.0 now. That was not a sequel I was excited about. And I think it's, again, the fact that that's being revived raises more questions than answers right now. But that was a key theme in the first Trump administration. I just don't think we saw it translate into a sort of whole of government policy agenda. This time around, you've seen much more assertive approach with respect to tariffs. Not pharmaceutical tariffs yet, although again, and the Wall Street Journal reported on this the other day, markets have been relatively cool in terms of pharmaceutical tariff prospects because the president said, oh, there will be a year or a year and a half, we're all kind of looking at these interviews wondering, what does that look like in policy practice? But that there's some sort of a runway or a grace period. But then I believe he also said in the same interview, 200%, which again, if you're a branded pharmaceutical company, if you're one of the ones who's been highlighted in the administration's press releases, and you've got massive profit margins, massive growth, blockbuster products, you may already be in the course of making major domestic manufacturing investments. I think it's a really open question. What does this mean for 90% of drug utilization in the country, which is generic drugs, where you've got thin margins? Marta's written extensively on this in a way that also helped to inform Polly's and my drug shortage work. But again, that's a really different market. And for the average everyday American, that's the type of drug they're consuming most of the time. So again, if you've got shortage risks and you've got companies that can't just overnight build up a new facility stateside, I think tariffs are a real threat in a way that they might not have been the last time around. Another area with this most favored nation approach, we'll get into that in more detail in a bit. I would say on that front, you had an executive order that came out that I think in some ways took the multi-pronged approach that a lot of stakeholders had wanted under Trump 1, where they said, okay, U.S. trade representative, figure out how you can leverage trade deals to try to effectuate and address pricing disparities. That was something that a lot of stakeholders from across the healthcare sector had asked for the first time around. But you also saw this push for folks to reach and achieve these most favored nation pricing targets across all markets, direct to consumer. And there was an or else. It was, if you don't make significant progress on this, we're going to pull the trigger. I don't think any of us know exactly what trigger they would be pulling and what that looks like. So for me, looking at the economy 5-10 years out, it's impossible to be able to model or price in what that looks like. There's a lot of unpredictability and volatility, but it is all in the name of a sort of America First agenda. I'll talk super briefly on the other buckets. There is an austerity-minded camp of folks in the administration who are big on budget is first and foremost the priority. I think we saw some of this coloring the physician fee schedule proposal that was released yesterday. I think we saw a lot of this in the OBB development. I've got to be honest, I think it's rare to see Senate Republicans go more aggressive than House Republicans. I was surprised that when my former colleagues came out with over $1 trillion in Medicaid cuts. And so, again, I think that also has a role in the way the administration's thinking about drug pricing. And it's not traditional Republicans so much as it is we need to spend less on healthcare. And then finally, I think that the newest addition to the president's coalition this time around was the sort of MAHA crew, the Make America Healthy Again crew. That is having cascading impacts across every single policy that we see from the administration. And I think it's the biggest departure from what we would assume from traditional Republicans. I don't think that the role of that sort of campaign mission, the secretary's agenda, that shouldn't be underestimated or downplayed with respect to the drug pricing agenda. Because I think about things like firing all of ACIP and replacing them with new folks. ACIP's policies have huge implications for affordability and coverage, including in Medicare and Medicaid with respect to vaccines. Again, we didn't see that kind of thing under Trump 1. I think similarly, there's a lot of talk about public health and prevention, but it's not prevention in the way that we've traditionally discussed it. I think about a condition like HIV. That's an area where I would say we've seen maybe the biggest breakthroughs in pharmaceutical science in the course of my lifetime, where you've seen an 87% decline in the AIDS death rate since 1995, when all of us were living. And I think about that type of prevention doesn't seem to be the type of preventive health that's at the thematic core of MAHA. I would say it's a posture that's sort of skeptical and suspicious of pharmaceutical interventions writ large. I think that's coloring a lot of the policy landscape. It's coloring the regulations we see. And it's facilitating, I think, a push away from the traditional public-private partnership and industry collaboration approach that I think has been central to our most successful healthcare initiatives over the years. Instead, I think it's bringing us into somewhat uncharted territories. So again, look, there's some talk about support for generics and biosimilars. Always like to hear that. But that's also coming in the midst of, again, budget austerity, including with respect to FDA. That was not a feature under the first Trump administration, at least not in practice. The MAHA agenda, which seems to be more rooted in if you eat foods without as many dyes, maybe you won't get cancer. Again, it's a different thing that I'm used to thinking about. And then finally, I think an America First approach across the government that is clearly coloring a lot of their healthcare initiatives. So again, that was overly long-winded, and I apologize, but I think as my colleagues and I will discuss further as this discussion continues, that's actually about as simplified and compact, I think, as you can get it, just because they are so much more active this time around, both in terms of statements and in terms of executive orders and regulatory action. It is really hard to keep track of. I think the president would probably take that as a massive compliment. But again, it's been an adventure already, and I can't believe we're not even a year in yet.
Well, there is so much to unpack, and I'm excited for this conversation. I'm worried 55 minutes is probably not enough time to cover everything that we need to talk about. But why don't we? There is one issue, Connor, actually you didn't mention, which is actually a perfect segue to Anna, is Medicare direct negotiation. And obviously, Anna, you spent a lot of time in your time, the Finance Committee, working to get that passed as part of the IRA. And as we're now looking at implementation, we're a few years in. And we have new guidance just came out from CMS. So I'm kind of curious if you could talk a little bit about how you view the implementation of Medicare direct negotiation and what else do you see kind of coming down the pike from that element?
Thanks. Yeah, it's a really good question. And we really waited with bated breath to see what the administration was going to do with this. It's interesting that Christy mentioned earlier that the notion that no one's tried to repeal the IRA the way that they've tried to repeal ACA, I mean, setting aside what they've done with OBB and other parts of the IRA, which, actually mattered for climate change. But I do think that plays into this. Interestingly enough, the administration hasn't been talking about it at the political level, I think, at the same, in the way that they have been through the executive orders. So, MFN and all of these things that have come out in that direction, although this is actually the one place where I could see MFN playing out potentially. But what I find really interesting is that the first thing is, the guidance when it came out was clearly obvious, it was obviously in flight during the Biden administration and clearly led by career staff who had the experience and so forth to sort of let this thing land. But what I liked about it, there were some glimpses in there that suggest that the administration is open to using this in the way it'll be most effective, which is to really be smart about what competition looks like for prescription drugs. An example for that is Keytruda and Opdivo and all of these biologics that are being reformulated from infused to injected by the addition of hyaluronidase, which is considered an active ingredient. So under CMS's approach to active ingredients, every new combination of distinct active ingredients is considered a new drug for the purposes of negotiation. And they very clearly signaled in this guidance and asked for feedback whether there are other considerations that should be taken into account, and if active ingredient is really the only deciding factor for whether or not that should be what distinguishes two qualifying single-source drugs from each other. And I think that's actually really important because, if you're going to negotiate, the whole purpose is to have available that negotiated price to people, and you don't want to have a situation where you have two versions of the same drug, one with a negotiated price, one without it, and the manufacturer has control over both, so they can encourage use of the higher priced one for obvious reasons, right? And so I think that solves an approach that sort of takes a more flexible view of what active ingredient does and what it contributes to the functioning of the drug is important because it really brings that under that sort of one umbrella. But the other reason I think it's critical is because you can start to have the conversation about value in a way that's about, well, what does this actually do for people? Okay, it means you don't have to go to the doctor's office and sit for an hour with an infusion. There might be some value to that, right? And that might be part of what the discussion is going to be about. But it doesn't, so it starts to talk about incremental value over the original, but it doesn't sort of treat them as completely distinct, quote unquote, pieces of innovation. But which I really like. We don't know yet which direction they're going to go, but I do think that is it's encouraging to see that inflection in the guidance. The other thing I'm going to be watching for is whether or not the administration continues to defend the law against legal challenges. I don't think there's been a ton of update there. I think it's kind of just continuing on, which is encouraging. If they really wanted to step back from it, of course, they could cease doing that. And then the other thing I'm going to be watching for starting in 2026 is really how the MFP gets implemented in the supply chain. Pharmacies are screaming bloody murder. I actually think that for the retail sector in particular, this is not going to be nearly as damaging as some of the pharmacies are sort of arguing it's going to be. It's actually potentially even beneficial. But I'm watching it closely because one of the elements of this law, one of the things it does is it really tries to delink the reimbursement from the service that's being added, right? So there's a component of delivering a product, of administering or prescribing a product to a patient that is value added. And, conceptually, there is a question of, should we really be subsidizing that through the spread price or the markup on a drug, or should we acknowledge that this value that is generated and provided by the provider and that they should be paid separately for it, right? So now there's this conversation about, well, should pharmacies be paid more on dispensing fees? We're also starting to hear it coming from Community Oncology Alliance, well known for their avid advocacy for higher drug prices, who also, want to actually keep the link between high prices and their reimbursement. And I think it's going to be interesting to see how that fight plays out. One, because we'll see next year what actually materializes and how disruptive it actually is to the supply chain. But also because I think it's going to be important to see how how Congress reacts to this, and whether or not they're going to be interested in hearing the argument of, we need an additional supply fee, or you need to roll back the MFP component of this and let the manufacturer true things up through rebates, which would really be a step backwards. So, one of the things that I think is going to be really important is making sure that MFP really does get applied at the point of sale and then it goes all the way through the supply chain. So that's what I'm really looking for.
That's a lot to unpack there. But I want to come back with Marta to where Connor kind of started on supply chain and tariffs. And Marta, you have written extensively on this issue, and I feel like we could also spend another 45 minutes just on supply chain and tariffs. But I think maybe given everything that's happening with the administration, we obviously have had a lot of conversation about supply chain broadly since COVID. And obviously in the drug pricing perspective, the two are you can't divorce the two. So can you talk a little bit about your work in the supply chain and on tariffs, and what are you seeing in the landscape and what's your perspective?
Thanks for the question. So as Connor mentioned, the issue around tariffs affecting pharmaceuticals has been kind of percolating from the beginning of this year. I will say we actually do have tariffs on some prescription drugs that predate the reciprocal tariffs, which did exempt pharmaceuticals. We currently actually have 20% tariffs on drugs from China, which doesn't mean that the finished dosage form has to be made in China. If the API is made in China and an Indian manufacturer uses a drug with Chinese API, they actually have to pay a 20% tariff on the declared value of the drug, which is going to be the finished dosage form for drugs. So just it's not that we don't have tariffs on drugs, we do, but it's sort of a smaller space for now. So I think what's helpful to think about is what are the kinds of problems that the administration is trying to address through tariffs. And I would say that there are three. One is simply, it's pure industrial policy. We want manufacturing jobs in the US. We want to be making, we want to have a strong manufacturing sector. So that's one. Another one really only touches branded products. And a lot of it has to do with Ireland. So it's different tax regimes in different countries. And when I talk to folks who are in this space, they say, how does a branded manufacturer select where to make the drug? The number one consideration is taxes. So So that really matters, and that's why so much of our prescription drugs, especially API, is made in Ireland, because they have a lower tax rate. And so, in a sense, why we are not, so much of it is being made outside of the US, it's tax avoidance. And this really only affects branded products, and the Trump administration has not been very happy about it. And you've heard President Trump mention this. Another reason is geopolitical risk and national security. So, the exposure there actually is much higher for generic drugs, and a lot of it has to do with pricing, but going the other way. We have set up systems to keep prices for generic drugs absolutely as low as possible. The only thing that matters is the price. Nothing else matters. Just the price, not reliability of supply. And so we have really driven manufacturing outside of the US, especially for solid oral dose products, first to India, and then sort of upstream supply chains have really shifted to China. I will say that if you were to try to track down a drug that's small molecule, which is chemically synthesized, you would have to, it probably will be more of an exception to find a drug that doesn't have something coming from China on the key starting materials, reagents, solvents. All the roads pretty much lead over there. And so there is a concern around national security risk, especially since COVID and the exposure that we might have. We have not had shortages because of geopolitical risk, but that risk is real. So the idea is, if we onshore, we solve all of these three problems. And one way you can do this is, the Trump administration has, tariffs very much are a tool that you can use. And I'll first give you an example of where tariffs have worked really well, which is syringes. So if you look at syringes, we tend to think about the drug supply chain ending with the vial or the IV bag or the, what's sold at the prescription. But in reality, a drug in a vial is useless if you can't get it into a patient's arm. We actually sort of very much came up during COVID, right? So it turns out that I did an analysis that wasn't published, but looking at data from 12 health systems in 250 hospitals, we looked at the share of inpatients who use drugs that come in a vial. And the percentage was 89%. So absolutely critical. If you don't have, but we had, post-COVID, we had 5 domestic manufacturers of syringes. China expanded capacity dramatically. And then they started dumping all of these syringes on the US market and drove, I think, 3 or 4 manufacturers out of business. They stopped making in the US. The last one was struggling. And not only that, but the FDA started seeing problems with Chinese syringes that weren't performing properly. I've never seen countrywide, it wasn't sort of an announcement to providers, watch for syringes from China. So the Biden administration, they came in and they said, we need to prop up the domestic manufacturing of syringes. So they imposed actually targeted tariffs on that, which then later on, the Trump administration, not because they were targeting it there, but all the China tariffs drove the prices of Chinese tariffs quite a bit. And now we actually have a robust domestic supply of syringes. We actually have these manufacturers reopen the factories, and now we have a supply. So the idea here is that, in a sense, you sort of impose a tax through a tariff, and it sort of levels the playing field. And so the idea is, why don't we do this to prescription drugs? The problem is that tariffs work really well in a couple of scenarios. One is if you have something to protect, or if you can really quickly sort of turn it back on, right? So here they were able to reopen this. But if we have moved all of our manufacturing, a lot of the manufacturing of solid oral dose to India, building in the US, I mean, it could be $1 billion a pop, and it takes 5 years. So the economics sort of, in a sense, we could potentially increase the margin for the manufacturer, but then the question is it worth the cost, the upfront cost? So that's one part. There's another part of how this could play out. In our efforts to really drive down prices, the government has put in a number of programs that cap prices. So 2017, I believe, Medicaid inflation rebate was put in place for generic drugs. And so now if a manufacturer would increase the price by more than a certain amount, they have to pay it back to the Medicaid program. And also that same price gets used in the 340B program. So let me sort of roll this forward of how, this could play out. So branded drugs, I think, would fare very differently in the tariff scenario. Number one, they actually have big margins. They can potentially absorb the tariffs, but they can also do a lot of other things that could minimize it. The amount of branded drugs that were moved prior to April into the US is astounding. It really is astounding how much. I think imports from Ireland tripled, from Switzerland was 5 to 6 times as much year over year. So one thing is you can move a lot of product in. Also, a lot of these companies have facilities in the US and outside of the US. And so instead of building a new facility, you can just move chairs around. So you'll basically reorganize your supply chains that you use the US facilities to just make product for the US, and you make for the rest of the world somewhere else. So that's sort of another thing that's going to be happening. And also you can potentially play various games with the prices and the declared value on the border. There are various sort of rules. You can sort of work with transfer pricing. So there are ways sort of to get around and to minimize this. So I frankly don't expect that there would be much pass-through, even if the branded manufacturers could increase prices because there's not much competition in the market. There's so much, so number one, they can minimize the impact of tariffs, but to the extent that they can't, there's so much at stake for them politically not to repeat this sort of insulin scenario where list prices go up. There's just between 340B, between PBM reform, between how the IRA, the Medicare negotiation plays out. The last thing manufacturers will want to do is to increase list prices and potentially expose themselves to more pressure from the president. So I would actually expect them to the extent that they can't minimize the impact of tariffs, is to actually probably eat it to a large extent. And then sort of wait out until there's a new administration in place. So that's branded drugs. On the generic drugs, I think the space is very different. You can't reorganize chairs anymore because there isn't, Sun Pharma doesn't have any facilities here. You also have really no buffer. Your margin might be several percentage points. You get put 20% tariff. You have no buffer to do this. Can you pass on the price? Potentially you could. We think of generics as perfect substitutes, right? But if 80% or 90% of the blood pressure medication is affected by a tariff, what will buyers do? They don't have anywhere else to go, right? So the prices can rise. The problem is much less in the retail setting and much more instead of the hospital setting. There are limits to what extent manufacturers can pass on prices. Number one, there are GPO contracts that are held. Now, maybe you could sort of get out of them for force majeure provisions, but the price caps, the Medicaid the Medicaid inflation rebate, and the 340B spillover are what really worry me. So you have a 25% tax increase. Your margin is, let's say, 5%. Inflation is, 2.7 now, not 2.4. And what happens then? You have large Medicaid exposure or large 340B exposure. You can't absorb that. So what do? You walk out. You walk away from the market. And so the higher the tariff and the higher the Medicaid exposure and the higher the 340B exposure, my expectation is that those drugs would actually just be walking out of the US market and just doing something else. So I've been very much watching how this administration is going to play in this space, and especially around generic drugs, and especially the fact that the Medicaid inflation rebate and 340B absolutely do not mix with tariffs, and so how they're going to handle that.
So a lot to unpack there as well. I think there's one issue we did not talk about that I think is a good segue to our conversation is direct-to-consumer advertising. And the first Trump administration obviously spent a lot of time on that. There was an executive order. There was a rule about adding elements of price to DTC. It obviously was stopped in the courts. But, as we're thinking about a world where we are, I think, understatement of the year, hyper partisan, there are a lot of bills in Congress and lots of discussion about issues that are bipartisan, and direct-to-consumer advertising is one of them. And so I think it's certainly possible we'll see changes come down the pike from the administration. There are several bipartisan bills on this issue. So free-for-all question, but opening up to the panelists, can you guys talk a little bit about how you see the direct-to-consumer advertising discussion and where you see policy changes, particularly, potentially coming down the pike? Maybe, Connor, I'll start with you, given it's a Trump administration priority.
Yes, it is a Trump administration priority. I will say I think this is a perfect example of an issue that the relevant Republican congressional leaders, and so again, as you said, there are bipartisan proposals on the Hill. Senator Grassley has been a champion on this issue for decades.
And has a willing partner in Senator Durbin.
Yes,
which 100%. Is nice. Yes.
So my former boss, Chairman Crapo, I believe on multiple occasions blocked unanimous consent attempts, just in the interest of candor, unanimous consent attempts for that legislation. I think the traditional Republican view, with exceptions like Senator Grassley, on this sort of issue has been not just a legalistic First Amendment defense, which I think is part of the conversation, because there will always be questions when you talk about advertising mandates, advertising limitations around how the courts might come down on some of those restrictions and requirements with respect to commercial speech. Again, I'm fortunately not an attorney, but I think that type of issue would get litigated if you saw even Congress enact legislation in this space. But I also think for a lot of Republicans, the key objections, and again, I say this not because it's a fringe viewpoint. I think this is the viewpoint of most GOP members on the Hill, and certainly in the Senate, and certainly with respect to the leadership, not just the relevant committees. The view has generally been, let's not start meddling in commercial speech and advertisements with respect to factual information, right? The view's always been FDA has an appropriate and valid role to play in terms of regulating information to ensure that we don't have snake oil salesman practices across the country, but that this is a separate issue. Objection number two has always been, as the Hill has discussed at great length in recent years, the list price can be a really misleading data point. Obviously, in some cases, you don't see a lot of price concessions. In other cases, like the insulin example, rebates were on average 85 to 90% of the list prices by the time that we saw biosimilars come onto the market. And again, I look at that as a perverse supply chain practice problem by the end, even if early on some of the price inflation was driven by manufacturers looking to expand margins. So number two, I think is the list price the right data point? Number three, relatedly, we want information to the public to be valuable, meaningful, and truthful. And I think with respect to the vast majority of Americans, folks have some sort of health insurance coverage. So there was a question of, do we expect these advertisements to devote 5 minutes to explaining, if you're on this type of plan, you might have a copay like this, but you may still be in your deductible phase. It's just, we have such a complex insurance and coverage landscape. And the last thing you want to do is for a patient who would incur $20 if they took a given drug that their doc may prescribe for them to say, oh, well, this says it's $10,000. I have no interest in it. And so, again, I think there are a lot of objections among a lot of Republicans. I think the key dynamics I'm watching are, number one, how much of a push does the administration make on this front? I would say Secretary Kennedy has been more critical of DTC ads than literally any administration official of any administration potentially in history, at least probably since the creation of the television.
You're almost going to sound a little bit like the president. I'm just going to give you like a little bit of a warning. It's like the biggest thing ever. So I'm kidding. In the history of the world.
So I will say, so I do think he really, he wrote in the pages of the Wall Street Journal, I believe last fall, that he thought, he called into question, should we ban these ads, which again is a step further than just a pricing mandate. Again, if the president and Secretary Kennedy were to make a pronounced push with Capitol Hill, I think there's a real question of whether even some of the Republican critics of these mandates in the past might find their way to Maha. I think the nomination of Secretary Kennedy early on, folks were saying, oh, Senate Republicans are not going to want a plaintiff bar trial lawyer who's been enmeshed in litigation against these companies for decades, Democrat, critical of literally every health innovation, critical of the food industry, farming stakeholders, hospitals, doctors. I think there was a real question early on of like, oh, are Senate Republicans going to embrace Secretary Kennedy? I think they did. The hearings, for the most part, they were extremely enthusiastic. So I don't want to underestimate a potential change in enthusiasm. And so, again, if there's a big admin push, I think that shifts. I think number two, does the administration try to replicate something like the regulatory approach they used the first time around? Candidly, that rule was vacated on a very simple procedural basis, which is to say it was using a catch-all authority in this Medicare statute. The courts have again and again said, this does not allow you to do anything that you've tried to do, right? Like that rules under that authority routinely fail. So again, I don't know that they would be any more successful this time around, but I am interested in whether things go that route. And then finally, I think there's a real question, and this is a similar dynamic to what I'm looking at with respect to MFN. Do we see something like what we saw with the prior authorization announcement with major health plans? Or like just this morning, I was looking over press releases and noticed that the White House issued a list of different food manufacturers and restaurants who had voluntarily decided to remove certain dyes and other artificial components from food products, which the administration touted as a success story. I think with both MFN and with DTC ads, I'm interested in whether behind the scenes there is a real push by the administration to receive voluntary commitments that can facilitate a victory lap without undertaking a policy process likely to be fraught with litigation, complexity, all of the above. So I think, again, there's reasons. I would not be surprised at all if they do go that route and say, look, all these companies made these commitments with respect to their DTC ads. And again, on an issue like this, depending on how those look, maybe that's a good thing. I am a trust but verify type person when it comes to these public announcements. But again, I also don't fault on that third prong, I don't fault the administration for trying to work with industry towards voluntary commitments if they're meaningful and if they are actual improvements. Again, this is one, though, where we probably won't know anything about it until the date that a press release comes out or that there's some event. But
I think the meaningful point is an important. I think the meaningful point would be an important one. But Anna, I see Anna kind of chomping the bit. Anna, do you want to weigh in?
I think it's an interesting, like in addition to sort of handicapping the chances of what might happen, I think it's important to kind of come back to like what's meaningful.
Right.
I think that the discussion around this has its place, but ultimately, if we're really looking for substantive action, I'm going to look elsewhere.
Got it. So, and Margaret,
I was just going to add, as you have been watching the GLP-1 compounding play space, I am quite sure that you have been wondering how do they get away with that kind of marketing, right? And it seems that the standard is dramatically different for pharmaceutical manufacturers and what they say and what compounders. I mean, you must have seen the Super Bowl ad from Hims. Well, what's interesting is that when Congress first passed laws in the late 90s around compounding, they actually had a provision in there limiting the kind of marketing that compounders can do. And the Supreme Court struck it down. So, sort of going that route I could imagine this being struck down in exactly the same way. And so going sort of with a voluntary program, if anything, it makes me nervous that now manufacturers are like, well, why do we have to play by different rules? And trying to push the envelope on this in this space. Just wanted to flag it in case, just sort of an interesting twist to know about how the law treats compounders very differently. And there was actually a Supreme Court ruling that no, it's illegal to have this kind of a provision in the law.
I do want to pivot in a second to MFN, but I think it's important on the DTC piece to note that, of course, in a world where we're having a conversation about austerity and government spending, DTC does definitely contribute to prices because we know manufacturers are spending, 8, 9, 10%. 8 or 9 of them are spending significant dollars on advertising. And so if you're spending that much on advertising and you're spending more on advertising than you are on research and development, what does that say about what the politics and what the economics are of a manufacturer? And so when we're thinking about biggest, government payers, whether it's Medicare or Medicaid, that does have an impact on what the prices are for consumers and for payers.
I will say one thing, which is I think I'd be cautious of saying that it contributes to it because they don't price based on cost. Right. So it's a bit
Sky's the
divorced from
limit.
that, right? So I will say it contributes to spending, but mostly by driving utilization.
Yeah, that's fair point. Fair point.
Exactly.
I think my point was more of like they're spending more on advertising than on research and development, and that's notable and somehow gets forgotten in this conversation sometimes.
Yeah, just to piggyback off of everybody's points, I think that the conversation, certainly like including list prices and DTC ads is still part of this conversation, but I also feel like given where RFK has been on some of these things, the conversation has shifted more to what is the tax treatment for these advertisements, but certainly changing that would have a greater impact. But, in Congress, we don't do these types of deals in a vacuum. Right. So the question that I ask myself is, what do I have to give up to get that multi-billion-dollar saver? And I think the answer to that question is pill penalty. Like, we're not going to let Medicare effectively negotiate the price of pills anymore. So even though there may be appetite to think bigger about DTC ads, I still would have anxiety that would then start, in the deal-making process, become something that could backfire on folks.
So I want to come back to MFN, but you mentioned pill penalty, and I think that's important for the conversation given how much the industry is focusing on that. So maybe, Polly, can you talk a little bit about that legislation, what the effort is, and how that played out in OBBB?
Sure. Well, maybe Connor might be able to say more about all of that than me. But yeah, no, I'm happy to share the Democratic perspective.
And also, I don't think anyone knows what pill penalty is. That's certainly a topic. I think it's in the Beltway conversation.
Yes.
But,
yes. So the pill penalty or the
and
EPIC
I think quotations
Act,
are important.
Yes. Yeah, that is pharma's branding. The pill penalty, also known as the EPIC Act, would take the amount of years that a small molecule drug has to be on the market before it could be eligible for negotiation up from 9 to 13, which would be parity with biologics. And, the industry has argued that the disparity between small molecules and biologics with respect to negotiation eligibility has contributed to, or is in the process of contributing to, sort of inequitable investments between those two types of drugs. And Anna has done a lot of research on this, and I'm sure can speak a lot more to whether or not that is a valid claim by the industry. I think from our perspective on the Democratic side of the aisle, we look at this, and because generic entry is happening usually around like the 12 and a half year mark, if you bump to 13, how many years a drug has, a small molecule has to be on the market before it can be negotiated. You're taking a ton of drugs off board. And in my view, that cuts against, the promise that was made under the Inflation Reduction Act for, us to come in and disrupt the status quo with respect to drug pricing in the United States for seniors. And so that is certainly a huge priority of the pharmaceutical industry. I don't think that it's one where you're going to see many Democrats, willing to wheel and deal regardless of like what, any type of offer that's put on the table. But it's, certainly something that we're going to be keeping an eye on for the rest of the Congress as, I'm sure the industry will try to attach it to any moving vehicle that they can.
Yeah.
And we touched on MFN, Most Favored Nation, but I think it's important we take a step back, talk a little bit about what that means. And I recognize that that's sort of like the $1,000 question because it has not been really defined. So kind of maybe, Anna, I'll start with you. Can you talk a little bit about MFN? What do we think that means in concept? Is it similar to IPI? Is it different? And then kind of what are you thinking about or looking out for as we're hearing lots of rumors about what the administration may be doing or talking about broadly?
Yeah, I mean, it's an interesting question. In truth, I've looked at all the various models and so forth, and at the end of the day, I think it comes back to a core concept, which is other countries pay less, and we'd like to pay less. Now, what's interesting about it is that if you go through a reference pricing dynamic, right, there is the inherent interest to raise the prices in other countries. I think Marta has some smart things to say about that, but I will just say that I find the MFN conversation to be interesting in the sense that it hasn't actually touched on negotiation yet. Right, because that's one place where you could really do it, or at least with the amount of risk that this industry is willing to take in terms of pushing the envelope on, what they'll get sued on. This seems to be like an obvious one. They haven't, which I find kind of interesting. There's a very scant roadmap for making it happen. This whole DTC thing is also like that they're supposed to be doing it under. It also seems a little bit odd. I will just say that ultimately. This is not a political projection. It's more just a reality check that we do reference pricing in the U.S. all the time, right? We reference to what the commercial sector pays for Medicaid. We do it for other places and so forth, right? If our experience of that should teach us something, which is that when manufacturers can raise their price in one sector, they're going to do it in order to accommodate the other. There's math you can do to figure out how to profit maximize under that structure, and they are going to do that math whether it's another country or it's another payer. And so I do think that, this is, of course, not the political conversation that we're having, but it'd be great if we could start to use the Overton window, as Polly said, has shifted, and it's important, I think, to keep that in mind. But it'd be great if we could use some of the political momentum that's been generated around this to talk about why it is that other countries get lower prices and whether or not we couldn't just get there ourselves by having a conversation about what we're not willing to pay for, right? I think that's the conversation we really, really don't want to have politically. And I do think that it's going to be a reckoning, especially, by the way, once the debt ceiling situation, or like once
we're going to come,
debt.
We're going to get there. We're going to get there. But Marta, do you want to?
Yeah, I just wanted to add a little bit about sort of most favored nation as a sort of a concept, not just in this last executive order, but just in general. And I will take you back with so many people in this room from Kaiser. I just absolutely have to tie it to Kaiser. And there's a really great tie-in. And that takes us back to 1990 and OBRA, when there was discussion initially about the Medicaid negotiating drug prices. And the big pharma really didn't like the idea, and so they proposed that instead of letting Medicaid negotiate, how about we institute best price, which is really a most favored nation. So basically, anybody getting a better, a price better than the mandated discount, that price would be available to Medicaid. And so Congress was like, "Wow, that sounds like such a great idea. We're going to save money for Medicaid." So it got implemented. I don't know, actually, Tony probably knows whether VA was exempt from the beginning or late. Oh, they weren't. Okay. So here's the problem. Medicaid was, as a buyer, I think maybe 10, 11%, much bigger than some other players that were getting really great discounts, like VA, like Kaiser, like some dish hospitals. And what ended up happening is that Medicaid did not get a better price. The prices were where they were mandated, but anybody who was small and got a better price than Medicaid, their discounts were wiped out. Basically, it became too expensive for the manufacturers to give them prices because then they have to give it to Medicaid. So Medicaid, VA got exempt immediately, and then there was a problem with dish hospitals and some of the cancer hospitals. And so Congress decided, okay, we're not going to be exempting everybody. We're going to create the 340B program. So that's sort of a story, a long story. So when Anna was sort of talking about how would this play out with MFN, well, one of the things, when the manufacturer now has tied, their hands are tied behind their back, they'll still say, okay, what should I be charging whom so I still make the most money? And sometimes it means not selling to someone. We don't want it to, we're going to tie it to Europeans, But then the question again is, how is this going to play out? And there's actually another sort of interesting piece here is that, we talk about sort of this Europe versus US price differential as being unfair. And the question is, what would be fair? What if the manufacturers respond by raising prices in Europe? Well, that would be fair, but that's not what we want, right? We want to pay less. So just something to think about. We don't know enough details about how this would be set up, but there are definitely unintended consequences to these kinds of kind of market interventions that are really important to think about.
One thing to add on to that, I think it's really interesting that even before MFN came out, we saw a couple of CEOs of big companies starting to test the idea of, hey, Europe, you should really pay more. And also maybe delist your prices from being published. And they'd be happy to do rebates, which sounds to me like exporting a very particular system everywhere else. So, they're prepared. I'm very sure that they're prepared to do it.
Not only that, if you look at Germany has enacted legislation that says if you pay a little bit more of a rebate than you normally would for certain products, you are allowed to keep the rebate level that you're providing to the government confidential. So they're literally paying for, and they're doing this in response explicitly to reference pricing regimes elsewhere in Europe. I find it hilarious that the folks who are saying some of the folks who are saying let's outsource all this decision making to Europe, they're not actually tracking what's happening in Europe or how any of these paradigms work, nor are they all that interested in some of the complexities here, because I think it really does come down to we don't like that we pay more here. And the other piece I would say is the administration, to their credit, seems very interested in a more transparent healthcare system. We saw executive orders on this front. We saw an RFI on how can we make drug pricing data with respect to the commercial market a little bit more transparent and usable, whether that's for tech companies that are going to serve as sort of interpreters of that data and leverage it for tools, or whether eventually this is for consumers. I think transparency is a good goal. The reality is our system is so complex and so opaque. We have all of these different programs with varying levels of discounts. We have 340B, which is growing, I think, year by year, even after some of these contract pharmacy limitations. And the fixation on the list price, I think, is frustrating on both sides of that issue. Because I think on one hand, there's a frustration that list prices for some of these products are so high, and the fact that consumers have to pay. Most insurers now have co-insurance for at least some products. That's a decision by pharmacy benefit managers and the insurer to say, we want to expose you to the list price, even if they're collecting sizable rebates. Deductibles have gone up over the years across different plans. Again, that's a decision by insurers and pharmacy benefit managers to say, we want to expose the consumer to more of the list price. So I think frustration with high list prices is completely human and completely natural. And I understand why the administration would look at differentials in list price and say, this is not working for a lot of patients. And frankly, if the uninsured rate goes up, as it is projected by CBO2, again, who knows how those estimates will go, whether there will be mitigation legislation. But the reality is, if we have a larger uninsured market than we have today, then actually list prices will end up mattering more. And programs people don't like donated drug programs or copay coupons are going to become more important and more widespread. But I think the other frustration with the list price fixation is a lot of the folks who are running ads and saying, look, list prices are egregious, big pharma is evil. They're not mentioning what the 340B discounts look like. They're not talking about Medicaid drug rebates.
But when you're talking about dollars spent, 340B is like a bucket. It's a few $1 billion a year relative to what Medicare or Medicaid or any commercial payer pays on drugs.
In Medicare, I don't see, the reality is most rebates in Medicare Part D, which again are small for some products and big for others, they're subject to non-disclosure agreements and confidential contracts such that there's transparency is impossible with those products. So again, I think folks are right to be frustrated with the list price fixation, both in the sense that there's a lot of complexity and nuance and a lot of complex discounting that's not particularly efficient going on in the market that's ignored by that, and by the fact that, unfortunately, we're in a system where the list price does matter to more and more consumers because of insurance policies and because we have an uninsured population.
So I'm going to take the prerogative as the moderator here, and I'm going to give myself the last word before we go to questions from the audience. But I think what's important in the list price conversation is you still see list prices going through the roof, even in drugs where there are no rebates. And so it'd be great if the pharmaceutical industry were to decide, oh, actually, maybe we should reduce prices. But we all know they're not going to do that. So list price does matter. I don't think we can divorce the two. And the final thing, again, as we're thinking about austerity too, like the list price, if we're talking about transparency, you can focus on everyone else in the supply chain, but unless you start with the manufacturer, how is the manufacturer determining the price of product is relevant to this conversation.
I do think, like, just, I know you wanted the last word, but
I feel like Holly and I are probably mine now, so I'll let it slide for now, but I'll yield back and reclaim my time in a moment.
I think it's possible that, like, everyone is right here, right? Like, the complexity that Connor is talking about, like, what he was saying is even reflected in something that Anna said about the importance of having the maximum fair price go all the way through the chain. Like, I think we'd all like to work to a world where it's like there is a transparent price that is reflective of what the actual price of that drug is, that goes through the supply chain, so stakeholders are not making money in various different ways off of a drug price.
But also the stakeholders have transparency, understand how a manufacturer prices the product.
Yes, that's the other end of the coin, which is that the industry has made it completely toxic to do any type of cost effectiveness or value assessment on a drug to figure out if that price is an actual fair price for that drug, which I think is like the reason why we're all here today, right? You know, based on like the title of this forum. So I feel like at some point those worlds have to collide, right? And actually, like, the Inflation Reduction Act is trying to like do a lot of that work through Medicare drug price negotiation. But now I'll stop grandstanding.
Okay, and I'll let you have the final word, and then we'll go to...
I vehemently agree with everything that's just been said. I just want to add one more thing, which is I think we haven't talked enough about the fact that having high list prices also means you probably have way higher net prices than we need to have. You know, we don't talk about the fact that that allows price discriminations in exactly the ways that Marta's just talked about. So, you know, yeah, we pay more. We pay more at every level. That's all.
Okay. So with that, happy to open up to the audience for questions. And also, if you could identify yourself and where you're from when you ask your question. Sean.
Hi, thanks, Lauren. I'm Sean Dixon. I'm with AHIP. I just wanted to ask, since we have a panel of such great folks here, how we should be thinking about the changes to the orphan drug exemption in Medicare negotiation that came through under OBBBA, scored at $5 billion increase in taxpayer spending, probably another $1 to $1.5 billion increase in beneficiary spending on premiums and cost sharing. What should we think about what this does for prescription drug affordability?
It's a great question.
Anna.
It's a really good question, and I'm asking myself the same thing. We need to be having a conversation about why it is that we're talking about orphan drugs and spending of $200 million or more in Medicare. Like, we just need to have that conversation. We should have been having that conversation when we exempted drugs that have only one sort of group of, like, designation, which is what the original IRA was, right? I mean, I was not in the policy conversation anywhere near it. In fact, when these incentives to prioritize orphan drug development were under development, but it seems to me that we've really kind of gone well past that and overshot the mark in terms of what's actually being developed. I've always had concerns that we are starting to focus more and more on rare disease development at the expense of other areas. And by the way, I think this is something that Maha might actually have an opinion on. But one of the provisions in that, it's not going to have, does it eviscerate the policy? No, fortunately, it's not epic. But it does raise some, I think there's a really weird precedent in there, which is that the second part of that provision goes, first of all, anything that's a pure orphan drug gets exempted from negotiation, full stop. But it also says that, it's the first non-orphan indication that starts the timer for negotiation eligibility. And yes, manufacturers are still going to develop for non-orphan indications. But all other things being equal, I think that's the first precedent I've seen where we really say explicitly, manufacturer prefer this one over that one, as opposed to here's an addition of something. And that really alarms me as a precedent.
I would say briefly, just given, my former, actually, both my former bosses were supportive of this legislation and were supportive of its inclusion and reconciliation. I will say Republicans on the Hill did, in undertaking this proposal, think seriously about trying to strike a balanced approach. And I think the reality is, in a room of 100 people, you're going to have 100 different perspectives on what exactly the right balance is. But the goal was, we have treated orphan drugs differently under the tax code, under the FDA regulatory process, under 340B, under any range of different pieces of legislation over the course of the past few decades. And I think for the Republicans and for some of the Democrats who supported this legislation, they saw and see this as a continuation of that special treatment with respect to orphan products, just given the unique and differentiated economics that are at hand when you're talking about a rare condition and a rare disease treatment. And again, I was supportive of the push. I worked on that legislation while I was on the Hill. I think that folks can have a good discussion about whether that strikes a great balance, but I do think it helped with the consideration that this did have some bipartisan support in both chambers, that it did fit within, again, a long-standing tradition of treating orphan products differently. And I think from the perspective of folks who supported the legislation, they saw it as striking an appropriate balance by averting certain forms of gaming, by saying you can't just get an orphan indication on your product and suddenly say, oh, I'm exempt from negotiation forever. I think the goal here was to say we're specifically describing a universe of rare specific products. And yet I think with respect to the runway, clock start, there are all sorts of different shorthands now in place with respect to the IRA. The goal of that provision was we also don't want to create an active follow-on disincentive for an effective rare disease product that has multiple rare indications for them to undertake development with respect to larger conditions with larger populations. The idea there, again, this is coming from Republican conferences who were respectfully, I hope I was always respectful about it, on the Hill, respectfully didn't support the IRA, right? And who I think by and large still have some distrust and apprehension about the drug price negotiation program, whether it's in the hands of a Democrat or Republican administration. And so I think because there's distrust of that mechanism, I think there was more comfort saying, okay, we're going to do both the clock start component of this and try to capture additional rare indications. But this was seen as a targeted, modest provision. It was not marketed by Republicans on the Hill as a big sweeping one. And I thought it was interesting that, this was probably the one surefire chance for Republicans to move the EPIC Act, that the pill penalty legislation, which does have a lot of Republican support on Capitol Hill, there's no question that would have been a significant change to the IRA. Some folks would say favorable, some folks would say less favorable, but that would have been a bigger provision and a bigger undertaking. I think this was seen as a fairly targeted carve-out specific to orphan products from members who care a lot about rare disease patients and who look at the fact that you have, 95% of rare diseases still have no FDA treatment option. Again, a lot of the same.
So we're almost at time, so I'm going to let Anna respond, and then we have time for maybe one or two more questions. But go ahead, Anna.
But I just want to point out, it sets up a tension between developing for rare and for non-rare. And I think on the margins, it's not going to have a huge policy impact per se. Companies are still going to want to develop for the bigger market. But it does set to me, a very disconcerting precedent, because it does say, do this, not that, for these types of patients. And, we're all patients someday. You'd want them to care about every patient life.
Okay, so on that note, we have time for probably one or two more questions, depending on how quickly our panelists can answer them. So Questions from the audience? Not a shy bunch. Oh, go ahead.
I just wondered what you make of, just as I was coming to work this morning, the FDA Markery saying about giving sort of this voucher incentive for companies that are fast tracking FDA approvals for companies that will, I forget how they said it, but you guys know what I mean, will like have their price to be more comparable to lower prices in other countries. Just wondering what you kind of make of that.
I don't know, Marta, I think we're all looking at you a little bit because it feels like it's in that supply chain tariff kind of dynamic.
So I don't think we have enough details about how it would be operationalized. So it's really hard to comment. But I will say one thing is that there is definitely room for prioritizing and sort of adding a policy component. If you think about, so I mean, there's definitely room for the administration to do something like this. I think some people have raised the question of like, is this legal? Well, there's nothing in FDA statute that talks about prioritizing first generics, right? And we have had the first generics policy for a really long time. It's a policy. So, there's certain things that FDA has to do. There are certain requirements that they must fulfill. And it's true with every agency. There's this room for kind of prioritizing things. So, it's not that they're not going to approve certain drugs in a certain amount of time and not meet their goals. They will exceed them, right? And so there's definitely room for it. Now, how will this be operationalized? I have no idea.
Would they still meet the same standards? I mean, that's the biggest question I have, because if they're willing to accept lower levels of evidence, then I think I'd have real questions about any of it.
Again, we don't know how this would be operationalized.
But that's a great question that
But
needs to be addressed.
that is a question, right? Mm-hmm. So, but I think it's not about drug prices and the trade-off. I mean, just the idea of having a 1-month review, whether or not it's tied to drug pricing or onshoring or anything else, you want to be raising those questions, right? Like, are we changing the standards in any way by doing that? But that's completely independent to, could we tie it to drug pricing somewhere else? So, and I was really more commenting to that other piece is like, I think so, yeah, why not? You were doing it for first generics, right?
So on that note, we could keep going, I think, for another 2 hours if we had more time. But I want to thank our panelists. Please join me in thanking our panelists, and thank you to Kaiser for hosting this conversation. Ceci, I'll turn it back over to you.
Thanks, everybody. What a great panel. Wow.